So today I'm going to be talking about the overview of current upsurge of Mpox in Africa. As a form of introduction, we know that Mpox, that was previously called monkeypox, was first described in captive monkeys in Denmark in 1958. But the first human case was reported in a 9-month-old boy in the Democratic Republic of Congo in 1970. And since 1970, Mpox has caused recurrent outbreaks in many parts of Central and West Africa. Mpox is caused by what we call the monkeypox virus, which is an autopox virus. It's a double-stranded DNA virus, and we know of two distinct genetic clades. The clade 1, which was formerly called the Congo basic clade, has a higher mortality than the clade 2, also formerly called the West African clade, based on their geographical location. Let's just talk briefly about the epidemiology of Mpox and look at the historical trends. The bar chart on the left-hand side gives us an overview of the number of cases of Mpox that have been seen between 1970 and 2021 human cases. And you can see from the chart that majority of cases were reported in the DRC. Unfortunately, most of these cases are suspected cases, and because of weaknesses in the health system, it has been difficult to confirm all suspected cases of Mpox in the DRC. The chart at the middle here gives us a trend analysis of the number of cases of Mpox that has been seen in the DRC and other countries, both in animals and humans. And you can see here from the chart that outbreaks began in animals in 1958, and there were other outbreaks between 1964 and 1968. Then the first human case was reported. Then cases were then reported between 1970 to 1989. But there was a tendency towards a rise in number of cases from 1997, especially in the DRC, and the cases continue to rise thereafter. The decline in cases that is reported here in 2020 to 21 might be related to the COVID-19 outbreak and the decline in the either exposure or public health surveillance related to Mpox. So between 1970 and 2021, Mpox had caused outbreaks and endemic and recurrent outbreaks in 10 African countries are listed here. But it has also been exported to other countries outside Africa. The first exportation occurred in the United States of America in 2003, when rodents were imported from Ghana, and these rodents infected pet dogs, and that resulted in 47 confirmed and probable cases of Mpox in parts of the United States of America. All cases were zoonotic related, and there was no single human-to-human transmission noted in this outbreak. The second exportation occurred following the Nigerian outbreak between 2017 and 2019, but especially 2019 to 2021, where a dozen of cases were exported to the United States of America, United Kingdom, Israel, and Singapore. There's also been a change in demographics of Mpox related to the age group that is most impacted. If you look at the column chart on the lower part of the screen, you'll see the trend of age distribution amongst cases seen in Central Africa. You'll notice that at the early phase of the outbreak, majority of cases were even below the age of 10 years, then below the age of 11 years. Over time, you can see that the age of the most affected group is gradually increasing. And currently, we know that for the West African clade, most of the people that are impacted are both children and adults became the significant group following the 2017 outbreak in Nigeria. But in the DRC, between 1970 to 2021, and even one will argue even up to date, children less than 15 years are the most impacted group. So this is the type of exposure and secondary attack rates of human Mpox, just to give us an insight how people are exposed, especially the endemic and the classical Mpox. Primary cases usually had contact with monkeys and other non-human primates, and what was reported that is either they captured, they skinned, or they prepared these animals for food. But it was also intriguing that a number of other people also worked with these animals, but did not develop Mpox. And most of these animals were found to be healthy animals. So it was not very clear whether the exposure and infection with Mpox was actually related to these animals or a contribution of another factor. Secondary cases are reported in the DRC at that time where individuals were sleeping in the same bed, eating with the same spoon and cup, or sleeping on the floor. But what was observed, if you look at the chart here, the table gives us the attack rates, primary and secondary attack rates in vaccinated, smallpox vaccinated and unvaccinated individuals. And you observe that the rate among the vaccinated individuals, unvaccinated individuals, is far higher than that of those that are not vaccinated, 7.9 to 0.2, and this is 7.3 to 0.3. This other chart below just gives us an overview of the contribution of animal source, human source, either secondary or tertiary or later, to the epidemiology of Mpox at that time. And you observe that most cases of Mpox between 1970 and 1983 were animal source, and there were a few human source. Most of the human source of transmission were not sustained. So the chains of transmission were limited and were not sustained. This is the epidemiological characteristics of the classical Mpox between 1970 to 2016. The classical Mpox is the typical Mpox that was described in the tropical rainforest areas of West and Central Africa, depicted in this chart here. You can see the tropical rainforest areas, which represents the various clades of Mpox. Most of the cases of Mpox reported between 1970 and 2016 were reported in rural settlements and in small villages with a population of between 5,000 to 10,000 people. And most of the people that were impacted and infected were children less than 15 years, and there was no significant differences in the sex distribution, although males had a slightly higher number of cases than females. In terms of the transmission dynamics and risk factors, greater than 70% of cases of Mpox were attributed to a zoonotic source. So animal-human spillover events, either the primary cases or the co-primary cases. There was limited human-to-human and mainly household transmission. And these transmissions were more amongst people that were unvaccinated. In terms of clinical features of the classical Mpox, it presented with a generalized febrile rash, which was more severe amongst unvaccinated. And as we have said earlier on, people with clade 1 had tended to have more severe disease than people with clade 2. So, but in 2017, there was the emergence of what I call the new Mpox, and this happened in Nigeria. In September 2017, Mpox or monkeypox reappeared in Nigeria after 38 years. The last case was reported in 1978. The index case presented to my hospital in Bayelsa. This patient is based in a rural settlement in the Agura community, which is essentially within the tropical rainforest areas known for Mpox. But something unusual happened subsequently. Subsequent cases were actually young adults between the ages of 20 to 40 years. We're expecting children less than 15 years to come to our hospital and across Nigeria. Majority of these cases were males. Majority were urban dwellers, and there was no established zoonotic source. And for the first time in history, we also reported an association between Mpox, significant genital ulcers, and STIs, including the HIV infection. What was also remarkable was the geographical spread. Mpox was, in this case, reported in 17 of the 37 states or 36 states and the Federal Capital Territory. Within a space of 3 months, 88 cases were reported. And that tells you there was an ongoing undetected transmission of Mpox in Nigeria before the September 2017 index case was reported. And also remarkable is that the disease is spreading outside the traditional rainforest areas, even to urban settlements. Fast forward to 2022, there was a global outbreak. In July 2022, the WHO declared Mpox a public health emergency of international concern because cases are spread to more than, by the end of December or so, cases are spread to more than 80 countries across the globe, almost all regions of the globe, and we are reporting close to 80,000 cases. There was intensified effort to control the outbreak across the globe, but especially in the global north, in Europe and America, and subsequently cases declined significantly, attributed to change in behavior and perhaps the use of vaccines. And so in May 2023, WHO declared the public health emergency over. But cases continue to rise in Africa, as you can see in this chart here. And what was remarkable about the global outbreak in 2022, 2023 is that it infected mostly gay and bisexual men. And close to 50% of the people that were infected were people living with HIV. And that suggested, with amongst other evidences, and sort of corroborated our findings in Nigeria in 2017 that the Mpox was transmitted via sexual contact. So what's the link between the Nigerian outbreak and the global outbreak? The number of studies have been done, including molecular studies, molecular clock analysis to look at where human-to-human transmission of Mpox actually started, using, of course, a deaminase-based mutation, ApoBec3-based mutation. And one of these studies suggested that it's probable that the sustained human-to-human transmission, or but cryptic human-to-human transmission of Mpox in Nigeria began at least in 2017. I think there are emerging studies yet to be published that has even shown that perhaps it emerged in 2014. And then subsequently, it was detected in 2017, then before it spread to other parts of the globe. So this shows us the various clades of sublineages of clade 2B. And you can see here that in 2017, 2018, when we had the Nigerian outbreak, we had the sublineage A3, A1, and the likes. Then 2018, 2019, there was exportation to Singapore, Israel, United Kingdom, also sublineage of clade 2B. Then in 2022, there was exportation again from Nigeria to the United States of America. Then 2022, there was a global outbreak. So you can see that the global outbreak and the Nigerian outbreak from 2017 and the exported cases have a common ancestors. That tells you that the origin of the global outbreak can be traced back to cryptic, undetected transmission, human-to-human transmission of Mpox in Nigeria. Let's come to the DRC. DRC is known for clade 1 from 1970. But there are two types of epidemiological patterns of Mpox in the DRC. There's the endemic Mpox and the non-endemic Mpox. The endemic Mpox is the one that emerged in 2023. I mean, that's been there since 1970, but it's increasing in number of cases. And if you can look at the chart at the middle here, you will observe that in 2022 alone, when you compare 2022 and 2023, you observe that there has been a 76% increase in the number of cases. And if you compare 2023 and at the same period, I think at the end of middle of August, there has been a 160% increase in number of cases reported in the DRC. Actually, most of these cases are actually suspected cases. The case fatality rate also indicates that children less than 5 years of age had a higher case fatality rate than other group of persons. What I was also observed is that provinces in the DRC that never reported the Mpox in the past, such as the city centers of Kinshasa and the eastern part of the DRC, started reporting cases. And that occurred related to the non-endemic Mpox. So a new clade of a new strain of sublineage of Mpox called clade 1B was first detected in South Kivu in September 2023. And what happened in this case, it was not circulating amongst children that was traditionally known for endemic Mpox. It was circulating amongst sex workers and heterosexual and their heterosexual partners. Of course, few children were also observed to have clade 1B. And what was remarkable, this was also the first time there was a sustained human-to-human transmission of a clade 1 strain. So from September 2023 to date, it is observed that there is sustained human-to-human transmission of this clade 1B to the extent that it has crossed the border from the eastern part of the DRC and also gone to countries that never reported Mpox in the past, including Uganda, Kenya, Burundi, and Uganda. And also remarkable is that this new strain, 1B, has, of course, ApoBec-related mutations, which suggest human-to-human transmission, and some gene deletions that creates a false negative PCR testing. So this figure just gives us an overview of the trend of Mpox between 2023 and 2024. And you observe that even when the public health emergency was declared over by the WHO, cases in the DRC continued to rise. This just gives us an epidemiological trend of Mpox in Africa, comparing it with the global trend. The first chart on the left-hand side gives us the epidemic curve global, showing us that cases declined significantly beginning in December or so, 2022, and then, but from 2023, cases have started to rise, especially in Africa. And if you look at the epidemic curve in Africa, you will notice that the substantial number of cases that were reported in 2022 were from Nigeria. Of course, this was reflected cases. More cases will have been reported in the DRC. But in 2023, we are now, from 2023 to 2024, we are now witnessing an increase and significant number of cases reported in the Democratic Republic of Congo. Of course, Burundi is also reporting a rising number of cases. In terms of global case distribution, you will see that the contribution of Africa is increasing over time, and Africa is having the largest share of number of cases since 2024. And this figure, this chart, this map at this end shows us the distribution of the various clades, telling us how clade 2B is restricted mainly to countries in West Africa and countries that reported new outbreaks in 2022, such as South Africa, then Cameroon with clade 1 and 2, then the DRC with 1A and 1B, and of course, Eastern African countries with 1B. So Mpox in Africa, as at the end of August 2024, 20 countries are reporting cases of Mpox or had reported cases of Mpox between 2022 and 2024, and these countries are listed here. What is remarkable here is that 5 countries, Burundi, Uganda, Kenya, Rwanda, Guinea, are reporting new outbreaks, and there has been significant increase in number of cases reported in the DRC and the Central African Republic, in South Africa, in Cote d'Ivoire. The number of cases in Nigeria are not as much as what was reported in 2023, of course, and the same applies in some other regions, like in Ghana. Ghana has not reported any cases. It's my view that this is an undercount and underrepresentation. There are a number of cases still in Africa, but because of the weakness in our surveillance system, we're not detecting most of these cases. So the number of cases in Africa is still underestimated, even in the DRC. So there was a declaration because of this challenge of Mpox, the emergence of a new strain, a rising trend, new outbreaks in new regions. There was a declaration of a public health emergency by the African CDC, then followed by the WHO, which is also remarkable. It's a call for countries to intensify surveillance and do all it takes to address the outbreak. So what are the drivers of Mpox upsurge in Africa? Of course, remarkable is the neglect and limited capacity. For 54 years, we have had Mpox, and we have not had vaccines, and we have not developed therapeutics. And even when the vaccines and therapeutics were developed, they were not available for African countries to use. There's persistent knowledge gaps. A lot we don't know about Mpox, including the reservoirs for the virus, the animal reservoir for the virus, and the natural history of the disease. There is limited lab testing, especially in the DRC and other parts of Africa. There's also weak surveillance systems. Second is predisposition, which is also very important. Africa has a relatively very young population. And what that means is that majority of the population had not had the benefit of a prior smallpox vaccine. And as we know, a smallpox vaccine provides a cross-protective benefit against Mpox. And so that is a significant risk factor, especially for Africa. HIV itself and varicella zoster virus are potential factors that could impact on the transmissibility and the clinical picture of Mpox, as we know. And I think this is an area that we need to focus on in Africa, because HIV is a significant challenge, and there are a number of people that are not virologically suppressed in Africa. Increased proximity to animal reservoirs are also very important, and due to urbanization, ecological changes, and which is ongoing in many parts of Africa, poverty, underdevelopment, humanitarian crisis, and this is a significant factor contributing to this outbreak in the DRC, where a number of cases are being reported, and there's a rising number of cases, and there's emergence of new strains because of sustained human-to-human transmission. Human mobility and interconnectedness is also very important. For instance, the spread of Mpox from the DRC to other Eastern African countries is related to human mobility, where the virus is transmitted by long-distance travelers and other travelers moving from one part of Africa to other parts of the world. Increasing cases that have been reported, for instance, in Sweden, is due to travel-related transmission. Then there is the issue of the pathogen. The monkeypox virus is rapidly evolving for a DNA virus, and is adapting continuously to the human host. And this is a significant factor that is driving the upsurge of Mpox in Africa. So what are the future directions? First, we need to increase and sustain investment in surveillance, research, and development. The word is sustained. It is not enough for us to start investing in Mpox just for a while. To address this problem, which has lingered for 54 years, will require a sustained, prolonged investment in surveillance, research, and development that is driven by Africa with the support from the global partners. We must deploy medical countermeasures and embed it with research. Of course, we know vaccines are available. Most of these vaccines have not been tested in the African setting, and there's an opportunity for them to be tested, whether vaccine efficacy or vaccine effectiveness study, and that is very important, that whatever we're deploying, we embed research. We must intensify risk communication and community engagement. There's a lot of falsehood about Mpox, also about Mpox vaccines, and this needs to be addressed in Africa. We must strengthen the African frontline health workforce for Mpox. Is also very important, and there's need to promote improve ownership and commitment from Africa. We must take our destiny into our hands and do all that it takes to address this problem in Africa. Ensure that we commit more resources and strengthen our public health system. What Africa needs is investment internally and also externally. And we must also build sustainable global partnership. So ultimately, I would say that Mpox originated in Africa, we know that, but it was neglected for 54 years. It caused a global outbreak because there was no much attention paid to the Nigerian outbreak in 2017. If we do not sustainably and increase our investment in addressing the problem in Africa, unfortunately, history might repeat itself related to Clade 1 and even Clade 2. Thank you for listening.